Welcome to Direct Supply's Continuing Education webinar series. Direct Supply offers monthly webinars on a variety of topics throughout the year. The topic for today is a new age in rehabilitation, changing landscapes and technological solutions. My name is Robin Malik, and I will be facilitating today's meeting. Please note, the information contained in this presentation is intended to provide general information, but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. Today's webinar will be presented by Bill Goulding and Fernando Correia. Bill Goulding is the National Director of Outcomes and Reimbursements for Aegis Therapies. He provides oversight for relationships with 21 different Medicare fiscal intermediaries and Medicare administrative contractors. He develops and implements tools and training focused upon improving clinical documentation and using clinical outcomes data in various regulatory and reimbursement environments. Under his direction, Aegis has collected over 7 million patient outcomes. Fernando is the Chief Medical Officer at Sword Health, a leading company in new technologies for rehabilitation. Fernando graduated in 2008 at the University of Coimbra, where he obtained an MD and MSc. He further specialized in neurology and did 2 fellowships in London, one at the Headache Department of the National Hospital for Neurology and Neurosurgery, and the other in the Epilepsy Service of the Great Ormond Street Hospital for Children. He was admitted as a Fellow of the European Board of Neurology in 2015. He also holds an Executive Master's degree in Health Management from Cattolica Porta Business School. And now, please welcome our first presenter, Bill Goulding.
Thanks very much. First of all, to remind ourselves what we do know about the future direction or potential future direction for post-acute care reimbursement. And the way we're going to remind us of what we do know is by reviewing some of the major regulatory and reimbursement initiatives that have come out over the last 7 or 8 years. And then, once we've reviewed them, to identify if there are consistencies across those various initiatives that might help us to determine how to position ourselves better by identifying what the value proposition is across these different initiatives. And so hopefully you'll agree by the end that there are some common threads that can help us to position our organizations. So regardless of what bad analogy you want to use, whether it's trying to read the writing on the wall or trying to read the tea leaves or looking into a crystal ball or just sticking your finger up to determine the direction of the wind, we find ourselves in this position as healthcare providers an awful lot because the regulatory and reimbursement environment seems to constantly be changing and going in different directions. And so it can be very frustrating. It can be overwhelming. So we're going to try and make some sense of that and maybe give you some concrete ideas on the technology side. I guess I want to challenge the assumption that we really don't know what direction the regulatory reimbursement environment in post-acute care is going. And I want to start by talking about some comments that the newly minted Secretary of Health and Human Services, Alex Azar, presented, and this was just literally within days after he went into the position. He presented to the Federation of American Hospitals, and this was about 2 months ago in early March. And I pulled aside some of the bulleted comments that I thought were most important, but he was very clear about the direction that he intends to take healthcare in general. One of the things he said was, and this should be no surprise to any of us, that he doesn't see any turning back to a system where they were paying for quantity rather than quality, or paying for volume rather than value, or as he put it, paying for procedures rather than value. And he clearly said that they wanted to charge forward. And he said that they were not interested in doing this in incremental steps. And he's not afraid of disrupting existing arrangements. And that theme came up several times during his presentation. And it was very interesting that he made it clear to remind everyone that he's the Secretary of Health and Human Services. He's not the director of Medicare and Medicaid services. That individual works for him. And so his scope is the entire American healthcare system. And he said he intends to use Medicare and Medicaid to drive a certain kind of change across the entire American healthcare system. He said he wants to use the heft or the market concentration that Medicare or Medicaid represent to change the entire American healthcare system. And so these were no small plans. He also said he does not intend to spend his time at the helm of Health and Human Services just working on tiny little projects, for instance, just building the very best joint replacement bundle. He wants to look at bold measures. He wants to move very quickly, again, not just to change Medicare and Medicaid, but the entire American healthcare system. And warned everyone, gave fair warning that this was not going to be a comfortable process for a lot of entrenched players or stakeholders. And his closing comments sounded nice and welcoming, but they also sounded a bit of a challenge or an alarm, depending on how you take it. Basically said that he hopes that they're going to look back at this administration as a significant inflection point in the journey towards value-based reimbursement or value-based care. And as I said, closed with an invitation / challenge, saying we want you to join us on this journey, but I assure you, change is possible, change is necessary, and change is coming. So in case we had any doubt. So we find ourselves again saying, okay, if you're moving towards a value-based care and reimbursement system, what do you mean by value? That's the big question. And so in these times of uncertainty, we've got to ask ourselves, well, what do we know? What are we certain of? And we know they're moving that value direction. What are the models of value that they put out there? And are there any consistencies? So as I inferred in the very beginning in my introduction, my goal is threefold: to look across some significant initiatives that have appeared over the last 7 or 8 years, to identify what they appear to tell us they're valuing and what that might mean for us. So let's start with the most recent one, PDPM. This is just 2 or 3 weeks old. The patient-driven payment model. For those of you who aren't sure, in the SNF, PPS world, in the skilled nursing facility PPS world, this came out in the proposed rule to be implemented as of October 1st of 2019. And so this is about 1.5 years off, and it's such a significant change they decided to propose it this far ahead of time to give everybody, including CMS, a chance to adjust their systems and to prepare for this sort of a model. But this is the model that they're proposing for care in the post-acute world, specifically in skilled nursing facilities. And so let's look at what they said in this model they are placing value on. The first thing is they were saying very clearly, we'll reimburse you under PDPM based upon certain patient conditions or characteristics. And by that, they mean certain medical diagnoses, certain pertinent comorbidities that they found to be impactful on the potential cost of care. And they also are going to reimburse us based upon each resident's functional ability from a nursing and from a therapy standpoint. Also, part of this PDPM model, as they said, we're also going to incent you via reimbursement to deliver that care over a shorter length of stay. And so for both therapies and for non-therapy ancillaries, there are incentives in there to deliver the care in a quality way, but over a shorter period of time. And the way that they do that is reimbursement changes as time goes on for therapy and for non-therapy ancillaries. So again, we don't want to get caught in the weeds of this particular proposal, but these were some of the major takeaways that gave us hint as to what they valued. And so what are our value opportunities that come from PDPM? Where might we position ourselves to be better? First of all, if we're not already, we need to be better at being diagnosticians, if you will, at accurate identification of ICD codes, of key comorbidities, and of key patient conditions, and not only identifying them, but capturing them from a reporting standpoint, because that becomes a big part of the coin of the realm. Secondly, we need to focus on accurate identification of patients' functional levels. And of course, measuring functional levels is going to be different depending on who it is that's asking. In this case, for PDPM, they're going to ask using measures that initially came from the CARE tool and are going to be collected in the MDS in section GG. And so that will be a significant change. It's a different way to measure function. And it's something that we need to not only understand, but to be very, very good and very accurate at, because that's going to be a significant part of the coin of the realm going forward. And then finally, as we said, obviously, we need to press ourselves and push the envelope, if you will, on delivering those services, having an impact on patients' functional levels over a shorter period of time. And so it challenges our service care delivery models. Let's look at another one. That was just the PDPM. Let's look at the mega rule. And so this comes from an entirely different initiative that came from an entirely different contractor's study and has been going on a different timeline. And so while that might be frustrating, I think we can find some things that are fairly common. So what does the mega rule seem to place value on? Well, first of all, they're all about being patient-centered, or the term that they use is person-centered. And so again, while the mega rule doesn't focus directly on reimbursement, it focuses on survey and compliance. And they're saying they will survey based upon the extent to which we can prove that we're patient-centered in the services that we deliver in post-acute care. They also place a high value on the extent to which we focus on analyzing our own processes, our own systems, and focusing on areas where we can improve quality. Again, this isn't new. Unlike the PDPM that we just went through, the mega rule is a current reality for us. But the focus is on identifying what they're telling us about what they value. So the value opportunities for us in the mega rule are, first of all, and you'll start to see some repeat here, and that's good news. If it sounds like I'm repeating myself, that's good. That means we're finding those commonalities. And so first of all, we need to get better at focusing on identifying the resident's prior level of function and giving them some authorship, some input into setting their goals for the discharge level of function that they're shooting for, as well as the discharge setting or the transition setting that they're looking for. And secondly, we need to get better at identifying systemic issues, things that might be leading to things such as falls and pressure ulcers and pain, et cetera, and identifying ways that we can improve our performance in those areas. Let's look at another one. Let's look at the BPCI initiatives. This is the bundled payment initiatives are really a collection of initiatives, and they're somewhat different, but they have commonalities. And I want to caution you against thinking that the bundled payment initiatives have fallen out of favor, or that they were a flavor of the month that might go away, because there were some bundled payment initiatives that were scheduled to go into play that were mandatory, that were backed off on, and they were made voluntary. And that doesn't necessarily mean that these initiatives hold less favor. What it means is this administration has never been in favor of going to states and saying this is a mandatory program that you must follow. It's a state rights view administration, and so they much prefer voluntary programs. But bundled payment initiatives are just too alluring to go away, and so they're going to be around for a while. So we still need to pay attention to them. They may be administered in different ways, but the concept makes too much sense. Because what they're saying is we're going to reimburse you based upon your ability to improve function over a shorter length of stay. Once again, you see some repeats here, but that's good news for us. While it's a very different initiative, they're looking for many of the same things. And then secondly, they're saying, we're also going to reimburse you based upon your ability to avoid certain adverse events. And different bundled payment initiatives will identify different adverse events. So for some, it'll be hospital readmissions. For others, it'll be a specific type of regression in function, et cetera. But without getting into the details of the different BPCI or bundled payment initiatives, the major focus is along these lines. And so the value opportunities for us are to put a premium on getting better at communication and coordination across the post-acute care spectrum with partners that we may have considered to be competitors previously in other care settings, or maybe even providing care in areas where we also provide the care but may not be doing it specifically for that resident in, let's say, outpatient or home health care. So that sort of communication and coordination on behalf of the patient is valued under bundled payment initiatives. And much like the mega rule, it places a premium on performance improvement programs, on looking at the quality of our programs and looking where we can improve our performance, and then focusing on only changing the function for the resident that is necessary to get them to the next transition setting. In other words, what are the barriers to this resident transitioning to their next desired setting? And so again, rather than trying to impact all function, as a therapist, what we train our therapists to do more and more is looking at barriers to discharge or barriers to transitioning for that resident. How about the IMPACT Act? The IMPACT Act has been around for a while. It has significant momentum going. You may or may not be aware that many of the things that are happening, that are rolling out year after year, are a result of the IMPACT Act. So the IMPACT Act has been with us for a while and will be with us for many years to come. So what are the major value indicators from the IMPACT Act? Again, you'll see some repeat here. IMPACT Act focuses on measuring and demonstrating improvement in function. And then secondly, to focus on getting a resident back to a community-based setting and avoiding the sort of regression that might lead to a readmission to the acute setting. And so again, getting the residents not only to the more independent settings, but frankly, the less expensive settings. And so the opportunities for us are to improve on measuring and demonstrating that we have made a change in function. Specifically for the IMPACT Act, that's via the CARE tool, via Section GG in the CARE tool. So it happens to be the same area that the PDPM, the first initiative that we looked at, the patient-driven payment model, measures function in the same way. And so that's a positive as well. Very different initiatives that came from very different time frames and very different contracts, but they're at least looking at measuring function in the same way. And the IMPACT Act wants to do this in all post-acute care settings, not just a skilled nursing facility. So it's beginning to slowly mandate that this is the way function is measured for self-care and mobility in inpatient rehab facilities, in LTACs, and down the road in home health as well. Secondly, we need to get better at that transition planning, or what we may have referred to in the past as discharge planning. How to help that patient transition or the resident transition to their next desired setting. And then again, avoiding adverse outcomes, focusing on the safety and quality monitoring or performance improvement programs to avoid those adverse outcomes. And then finally, the last one I want to look at before we begin to pull this together and say what are the commonalities is the 5-star system. The 5-star system stretches across the post-acute care continuum in different ways, but with the same overall focus. The 5-star system is basically public radar screens, if you will, that can be seen by the consumer public that report on certain aspects of our business. And they are either lauding us or shaming us based upon our ability to improve function and to avoid regression. This should sound familiar, and hopefully it does. And they're also lauding us or shaming us based upon our ability to return residents to more independent, meaning less costly setting, and to avoid that backsliding. So very much the same as the Impact Act. You'll notice that essentially word for word, even though it's a different initiative, it's focused in the same areas. And the messages for us from a value opportunity standpoint are the same. How can we get better at demonstrating improvement in function? Now, right now, the 5-star system is measuring change in function essentially in Section G of the MDS in the SNF setting. But as you've seen, the Impact Act and the patient-driven payment model have shifted to the way that they measure improvement in function in Section GG. I would not be surprised that down the road, if the 5-star system shifts over to Section GG as well, just to get that continuity, that consistency. But again, the value opportunities for us are to focus on that transition planning and focusing on avoiding adverse outcomes. So these are of these key initiatives, these apparently disparate initiatives over the last 7 or 8 years, these are the value opportunities. Getting better at demonstrating and actually being more patient or person-centered, involving them in the process, identifying accurately and recording and reporting residents' conditions, complications, comorbidities, diagnoses, those sorts of things, especially those that have been identified to be related to cost and care needs. Thirdly, focusing on measuring improvement and, in some cases, the maintenance of function, in other words, avoiding regression, in the coin of the realm or in the using the ruler that each of these initiatives tells us that they want to use. And as I mentioned, several of them are beginning to move towards similar rulers, similar currency, if you will. Focusing on avoiding adverse events, and those adverse events are going to be identified differently by these different initiatives, but we've certainly seen some commonalities. Readmittance to acute care, falls, pain, skin ulcers, those sorts of things. Getting better at collaborating with entities that we previously considered to be competitors. On behalf of the patient, collaborating and communicating with them across the post-acute care spectrum. And then finally, doing all of that in as efficient or affordable method as possible. So what are the key takeaways here? I would say that what I would hope you would take away is that while it might be easy to be overwhelmed by this alphabet soup that constantly comes our direction, all these different payment initiatives that seem to be so different, seem to be funded by different groups, backed by different contractors' studies, et cetera. It's easy to be overwhelmed by that, and it's easy to think that at times they're contradicting each other. And it's easy to think, oh, that's just going to be the flavor of the month, and this too shall pass. So I don't need to really pay attention to, let's say, the patient-driven payment model that just came out for SNF PPS. In actuality, I'm hoping to have convinced you a little bit that there's less contradiction than we may think, that there's more consistency, at least of direction, if not detail, than we think. So we can begin to prepare ourselves. We can right now begin to make a difference, come what may as far as future changes. If we increase our focus on 4 or 5 things here, personalized or customized care, demonstrating really clearly that that's what we do. Getting better at diagnostics and prognostics, being able to say we can name that tune in 5 notes, so to speak. We can get that resident to climbing stairs in 11 days or whatever the case may be. Being able to stick our necks out clinically along those lines, being able to measure change or the impact we have on residents and being able to demonstrate it in a measure that each shareholder understands, whether that's the patient and the family or the payer or the regulator. As we mentioned before, communication and collaboration across the spectrum, even if we're talking about doing that with those that we previously considered to be competitors. And then finally, doing all of that in as cost-efficient a manner as we can, constantly pushing for how we can do that as efficiently as possible. So it's as easy as that. It seems fairly simple, but obviously, after painting the landscape, what we want to talk about is maybe some more specific ideas as to how some of these things can be accomplished, specifically today from a technological standpoint. And so I'm going to pass the torch to Dr. Correia to take you on the next leg of the journey here.
All right, excellent. Thank you so much, Bill. We do want to stop and just take a couple questions if anyone has questions for Bill, and then we'll move on to the second portion of our event today. So while I switch it over to Fernando here, let's take a couple questions for Bill. One that came in is the PDPM the same as RCS1?
Yeah, that's a great question. So essentially the short answer is RCS1 led to PDPM. So RCS1 was the first iteration of CMS's plan for change. And it was fairly significantly, based upon the comments, CMS was overwhelmed, but really pleased by the comments that came in. And based upon the comments, they decided to significantly redesign what was RCS1 so significantly that they renamed it. And so PDPM is the outgrowth of RCS1.
Great, thank you. Second question. I'm an administrator in a large SNF. 80% of our patients are Part A, and our average length of stay is 13 days. What more, if anything, should I be asking my therapy provider to do to help me run my business more efficiently and effectively?
Yeah, well, that's definitely efficient. That's an aggressive length of stay. It's in the right direction, and so I would suggest that you continue the focus on efficiency, but also not to throw effectiveness out the window. And so I think I would challenge the rehab provider, especially with such short length of stays, to not have their blinders on, to try to coordinate care across the episode, even if you may not be directly involved from a reimbursement standpoint, to begin to coordinate across the episode. And so I would ask them how they're communicating with the next transition setting, to whom they're passing the torch, so to speak, from a care standpoint. So whether it's outpatient or home health or whatever the case may be, how are they communicating, coordinating, to ensure that that torch is passed as efficiently as possible, that there's not a disruption in care, and that they're not focusing so heavily on that short length of stay that they might be increasing the likelihood of some adverse events, such as a fall or an unexpected physician visit or a readmission to acute care.
All right, thank you. Next question. If the new payment model is not rolled out in October, when do they think the new rule will be final regarding reimbursement?
This new payment model, the proposed rule that came out in the normal schedule in the very last days of April, proposed very minor changes for this coming October 1st. There was a market basket increase for skilled nursing facilities, but not a lot in the way of process. And so this PDPM model is proposed to be implemented October 1st of 2019. Because there were really significant changes, and they knew that the software developers, the care providers, and CMS, for that matter, needed that much time to ramp up for it. And so there'll be another round of rulemaking for skilled nursing. First of all, can encourage everyone to give comments by the end of June on what they proposed already. They'll finalize the rule for this coming October 1st. There may be some further comments on the patient-driven payer model in that. But then next May, when the normal round of proposed rulemaking comes out for the skilled nursing facility, we'll see if they've tweaked this model even further. But they have every intention right now of rolling it out October 1st of 2019.
All right. Well, thank you so much, Bill. And now we're going to pass it over to Fernando for his portion.
Hello, everyone. And thank you, Bill, for such an interesting presentation. Being from Portugal with a significant presence in the U.S., it's difficult for us as a company to follow the landscape. And I'm glad that we've discovered that there is some common ground between all the initiatives. First of all, as a disclosure, I'm the Chief Medical Officer at Source Health, so I'm kind of biased. I have equity in the company, and here's my disclosure. I try to be as unbiased as possible, but please bear in mind this. I don't want to influence you. I just want to lay out what's out there and demonstrate how we feel is the way to go. I'm not going to focus on electronic health records. Most of you are thinking now that in order to get better at coding the diagnosis, the comorbidities, and in order to better coordinate care without losing many more hours in reporting and writing in electronic health records, you would need better health records. Well, it might be true, but I'm not going to focus on that. We are going to focus more on PT and OT and how technological solutions can help bring the gap and can help you take control of the opportunities that are out there. So, first things first, I'll start with the healthcare trends that Bill has thoroughly reviewed in this presentation. And the trends are for cost-effective approaches, also for preventive care, example, falls prevention in community-dwelling elderly patients, and the increase in efficiency and coordination of care across the whole spectrum. We also need to become better patient-centered, and we should take rehabilitation setting towards the community, either through an earlier discharge from hospitals or through a discharge home directly, bypassing SNFs, or at least reducing length of stay, and going to home-based care. So we think that home-based care or community-based care will be the way to unlock all the potential that's out there in the new value-based programs. Now, the problem is current systems and processes are tuned for a pay-per-service model, and this changing brings a lot of challenges. First of all, how do we ensure widespread access to rehabilitation? Currently, in a model based in a pay-per-service, patients who are out are out. So if you've got surgery and if you did not have effective rehabilitation, the hospital would still get the money for the surgery. And if the patient is lost, it's a loss of profit for the rehabilitation facility. But these bundle payments or these pay-per-value systems will force communication between hospitals and skilled nursing facilities and assisted living facilities or home-based care across the whole spectrum, because if you lose the patient in any of these points, you lose the ability of maximizing the outcomes, and this will be negatively reflected in terms of how you get paid for it. The other problem is how to standardize and measure outcomes. Now, we've seen in Bill's presentation that a lot of focus is going to be on measuring function. In terms of physical rehabilitation, for example, we already know from the literature that, for example, in the total knee replacement, increasing the range of motion over 90 degrees of knee flexion does not correlate well with the gains in function. Now, the essence of this is, instead of focusing on objective measures do need to be certainly as objective as possible, but a certain degree of subjectivity might be allowed. And this translates into, for example, being relying more and more on patient-reported outcome scales, such as, for example, the Quick Dash score for shoulder, the HOS, HOOS for hip osteoarthritis, the KOOS for knee. And so patient-reported outcomes are going to become more and more important in the way we report functionality and how patients relate to the disease. The other problem is, in musculoskeletal disorders, as well as in neurological disorders, now that we're focusing on PT and OT, there is a direct correlation between intensity and the outcomes. This is true for neurological disorders, but also true for musculoskeletal disorders. The problem is, if the only thing that's paid currently is direct contact, direct and specialized contact between the therapist and the patient, how are we going to increase the intensity and therefore maximize outcomes without relying on sheer manpower? This is a huge problem. Plus, bringing care home is expensive and requires heavy logistics. If therapists need to go home, they need to grab a car, grab an Uber, a Cabify, whatever. You need to pack a lot more hours. A therapist will need 1.5 hours, 2 hours just to provide 1 hour of therapy. So the direction cannot be to depend solely on the presence of the physical therapist or the occupational therapist together with the patient. And we believe that there is room for this in this new world order, so to speak. So the solution, technology, is a big word, yes, but technology isn't actually new. Technology has been around for 50 years, and in pelvic rehabilitation, for example, no physical therapist even considers now not using biofeedback to rehabilitate their patients. So in certain areas of physical rehabilitation, these new technologies, biofeedback tools, have been around for a lot of time and are currently being used. However, not all technology serves this purpose. We need to use technology that can extend the therapeutic footprint of the clinical teams in such a way that rehabilitation activities can take place without the physical presence of the therapist, while still ensuring clinical outcomes and also the possibility of remote monitoring. It's still, and it must remain, specialized care. Therefore, we are looking for technology that is safe, effective, enabling at least the same, if not better, outcomes. Technology does not need to be better than a human being, but technology is scalable and a human being is not. So, as in chess, where the combination of man and supercomputers is the winning combination, why don't we apply this to rehabilitation? Technology needs to be portable, needs to follow the patient, ideally during the transitions, the transitions of setting from the hospital to SNF to assisted living or whatever, or home care. Technology needs to be simple and engaging and allow independent use by patients, many of whom are elderly patients and have low educational levels and low technology literacy. Technology needs to be scalable, enabling remote monitoring of patient performance and adapting the programs according to this information. But it also needs to be low cost. There's actually no point in bringing technological solutions in if they're more expensive than working with actual real people. And plus, it needs to cover all contexts. It is with this framework in mind that I'm going to analyze what technological solutions are out there. So there are things that are high-tech, yes, but are not a real solution. Robotic devices have demonstrated interesting but modest impacts on multifunctions in patients with neurological disorders. They have mostly been tested scientifically on neurological disorders, but they're complex and costly. and this limits their application, their availability, and their widespread use. I'm speaking of solutions like Hokoma, with their Exo with their exoskeleton, and Hokoma with their locomats and everything. All these technologies are only available in specialized centers and cannot be brought towards patients' homes. Less bulky are the Motion solutions, but still, these are workstations, if you will. They can be used, all of these tools, in highly financed hospitals to get patients better faster, but only through the limited amount of time that patients spend in these facilities. Some SNFs could also have these, but again, this does not ensure these are not solutions that can be easily used across all the settings, and they certainly cannot be placed widespread on patients' homes. Potential solutions, however, can be camera-based, and these are based on, for example, Microsoft Kinect. And there are two companies based in the U.S. that use this kind of technology. One is RespondWell, and the other is Reflection Health. From these two, RespondWell has been acquired by Zimmer, one of the largest groups that manufactures prostheses. And the idea behind this acquisition was, again, to provide not only the material that's going to be placed on the patient or in the patient, but also to provide a solution, an effective solution for rehabilitating these patients. RespondWell, their website is down since they were acquired by Zimmer, so I don't know what happened to them. Reflection Health has had significant funding over the last few years. However, these two solutions have a problem. Microsoft, as of last year, decided to stop making Microsoft Kinect. There's not going to be another version of Microsoft Kinect out there. Microsoft Kinect was developed for use in the gaming scenario paired with the Xbox 360. And the problem with these companies is that they use a mainstream technology that has some known limitations on movement tracking in real-world scenarios, but they were trying to work around it when Microsoft pulled the hat and stopped making Microsoft Kinect. Now, there are solutions based on the Nintendo Wii Fit platform. These are very promising solutions. Still, the problem with them is, and we don't know why, there hasn't been a company, at least not one available in the U.S. or commercializing this in the U.S., that has taken the Nintendo Wii Fit console and adapted the games or developed new games for specifically for rehabilitation purposes. There are studies with the Nintendo Wii Fit platform. These come from these are academia-based studies, and it's a widespread solution. I mean, granted, it's more for the lower limbs rehabilitation, but we see a potential widespread application of such a platform in rehabilitating musculoskeletal disorders affecting the lower limbs. Still, there's very scant clinical validation on these tools. The advantages of these two solutions is that, of course, they're portable, they're low cost, they're simple to set up and to use, don't require constant therapist supervision, because all the data can be sent to a web-based portal and be available for the clinical teams to remotely monitor patient progress and adapt the programs accordingly. However, as I've said before, Microsoft stopped producing Kinect, and there is no commercially available solution based on Nintendo Wii Fit, and both use mainstream gaming technology that has shown some limitations in terms of full kinematic movement tracking. There is, however, preliminary validation of the EFIC console as an adjunct to conventional therapy after total knee replacement or ACL reconstruction. As a footnote, we expect that new groups and new companies will pick up the Nintendo Wii, at least for musculoskeletal disorders in the lower limbs, and we expect that in the next few years we'll have more evidence on solutions based on the Nintendo Wii Fit platform. Promising solutions are IMU-based systems. Inertial motion tracking systems have mostly been used as movement tracking tools with high accuracy, comparable to those big camera systems with rooms filled with 15 cameras at the same time. Still, they have seldomly been integrated in actual rehabilitation solutions. They have been used mostly in laboratories for movement tracking, but not for rehabilitation. And only now, in the last 3 to 4 years, have they begun to be incorporated in rehabilitation systems. Essentially, there are 3 companies working with IMU-based systems. Sword Health, our company, Hinge Health, a UK-based company who has recently opened headquarters in San Francisco, and Rehab. These are Italian, and as far as we know, are not commercially available in the US. So all of them, as you can see, use simple motion trackers that are strapped to the patient body using Velcro sensors. These sensors are placed one per segment and can be used to actually, and very accurately, produce a 3D analysis of patient motion and then provide feedback either through a tablet or a TV. And all of them, all these 3 companies complement this with a web-based platform that can allow remote monitoring from the clinical teams on remote prescription and remote editing of prescription. The advantages is these are accurate, portable, also low cost. We are in the region of maybe, I don't know, a few thousand. I don't know the cost of the price points of the other companies. They're relatively simple to set up and to use. Yes, it's true. Some older patients have some difficulty using or placing the straps, but this is not a limitation that cannot be overcome by a carer, because they're very simple to set up, as you'll see in the second part of this webinar. And all these tools have been validated for independent patient use. The disadvantages are the need to place straps. They're influenced by magnetic fields. This is a known limitation of inertial motion-based solutions, and all these companies are working around that. This is less of a problem at home. This is why these systems are particularly suitable for home care use. And again, there is still limited clinical validation with these systems, but it does exist, as I'm going to show you in a minute. And plus, Rehab is not available in the US. So, Sword Health has performed 2 clinical studies currently in publication mode, and we have compared rehabilitation after total hip or knee replacement at home under remote monitoring from a personal trainer, from a physical therapist, and we have compared 8 weeks rehab versus 8 weeks of home-based therapy, 3 times per week, 1 hour, 3 times per week with a PT. And at the end of the 8 weeks, both in the hip replacement study and the knee replacement study, we were superior. Rehabilitation using Sword Phoenix was superior in all measured outcomes, and the adverse events were similar in both groups. So these two studies, and each study enrolled 60 patients, 30 in each group, demonstrate that these systems can be used independently by the patients in their homes, in the comfort of their homes, can achieve the same or better outcomes, and with similar adverse events. Mind you, there was still a physical therapist behind the system in each case. So prescription, monitoring, and editing prescription, these are skilled care are still provided by physical therapists. So this is one aspect. We, as in Soul Health, have been focusing on the acute context, whereas Hinge Health has already published evidence on a more chronic setting aimed at private insured companies. They did a study where they wanted to see how clinical outcomes of a 12-week program in patients with chronic knee osteoarthritis. And they have proven in this study that a 12-month program with very high patient adherence in the region of 83% was able to increase function and decrease pain and symptoms. And these benefits were maintained at 6 months. Again, this is a home-based setting with patients still using the system independently under remote care from physical therapists. So in conclusion, there are clear trends regarding future directions for healthcare systems in the U.S. These trends will necessarily imply the use of technological solutions that enable care to be brought towards the patient, either at home or in skilled nursing facilities or even in a hospital, when the physical therapists are not there, in order to increase treatment intensity and therefore provide better outcomes without requiring constant therapist time. But only those solutions that are low cost, portable, can be a real solution. There is still limited clinical validation to guide decisions and to help break the ice. These are very new technologies, a very different way of interpreting what is rehabilitation and the role of the physical therapist or the occupational therapist in all of this. And so clinical validation is needed at least to break the ice, but nevertheless the timing is now to start testing these solutions, to start piloting these solutions. So when the tide effectively hits, you're already on the other side of the curve. Thank you very much.
Thank you so much, Fernando. We appreciate your time. We have time for a few questions. When I'm treating patients, I'm also assessing tolerance, fatigue, pain, and more. I'm not sure how I would do that remotely. Can you talk about that?
Yes, I can. I can tell you what we're doing at Soul Health. So at the end of each session, in the tablet, as you're going to see in part 2, there's a pop-up window that asks the patient to graduate the pain and fatigue throughout the session, and this helps us measure remotely the changes that we need to introduce in the program. Plus, because every repetition is counted and you can remotely see what the patient has done, you can get the feeling if the patient is not tolerating the exercises, too much fatigue, or is feeling pain, through a decrease in patient performance. This is how we do it with our platform, and I'm not sure how the other companies do it, but still it is possible to get a grasp of how the patient has behaved during the session in these 3 measures.
Excellent, thank you. And as you mentioned, we are going to be demoing that in just a second here. One more question that came in. Let's see. How will these technology models work with the elderly, cognitively impaired resident?
Well, I can only say that. I can answer that question twofold. First is in assisted living facilities and in cognitively diminished patients. Very few of them don't need any assistance in in 24 hours. So even if the physical therapist or the occupational therapist is not there, they have a carer who can help them. Second, in the clinical studies we performed, we have a mean patient age of 70 years old. Now, around 40% of these patients could not interact with the system by themselves, but they did have a carer beside them. And because rehabilitation activities with these systems can occur when and where it's more comfortable for the patient, we can work around these limitations and provide a carer or an assistant to help the patient interact with these systems.
Well, thank you so much to Bill and Fernando. We really appreciate your time today. And we thank you all for attending as well. And now for anyone who is interested in seeing a demo of the SWORD product that Fernando mentioned, please help me welcome our Director of Clinical and Rehab Category Management, Peter Klug.
Hi, everybody. I'm here with Shelley Wade, who I will refer to from now on as Kelly Sullivan, our patient. I wanted to thank Bill and Fernando, good friends of Direct Supply, for giving that presentation. Fantastic learning from both of them on really what's going on in the industry and what the technologies are that can help us solve those issues. So here at Direct Supply, we have a technology and innovation center that looks at 1,800 startups that are doing new technologies in the space of senior care. Through that funnel, we try and find the best of class. Sword Phoenix is certainly one of those, and I wanted to spend a little time sharing with you the Sword Phoenix solution today to help you think about how you might integrate technology into your practice today. So Sword Phoenix, Dr. Correia described it as being able to use it at home. Think about some other use cases as well. Think about somebody who's in a short stay SNF, who maybe gets therapy every day but wants an extra exercise session, and maybe a restorative aid is able to help a patient do those extra sessions in between therapy sessions to really reduce that length of stay. Think about somebody in an outpatient setting or even in an assisted living setting, getting extra repetitions and extra exercise. And really what we'd love to have your help in is really understanding where those scenarios work, and then doing pilots with us at Direct Supply and folks like Sword Phoenix to really validate that they work in those particular use cases. So without further ado, I want to walk you through the Sword Phoenix solution. Right now you're seeing on your screen a patient setup screen. So Kelly Sullivan, Kelly, is our patient. I've set up 2 exercises for her to do through my therapist portal. She's going to work on her left arm. I'm going to ask her to put on 3 straps while I'm setting up her patient profile here. 1 wrist, one on her bicep, and 1 strap across the chest. What those 3 straps will do is help her be mapped in 3 dimensions for the system. I'm now going to pick her patient card, and it's going to ask me if I want to do a new session with this patient, Kelly Sullivan, and I do. The system is going to ask me what group of exercises. I've grouped 2 exercises together into a session, so there's only 1 choice here. I'm going to pick that choice and get started. The session is ready to go, and it's going to ask me to put these sensors. Blue goes to blue, green goes to green, and red goes to red. And then it's going to ask me just to calibrate. Okay, we're all calibrated and ready to go.
In this exercise, standing tall with your arm alongside the body, move your arm to the side, keeping your elbows straight.
So each exercise is demoed on the tablet, so the patient has a chance to review the exercise right before they get started with it. I've set a range of motion target at 90 degrees for Shelley, so I'm going to ask her to try and get up to 90 degrees. And when she does, she'll get a little knowledge, a little bonus star for getting 90 degrees. And if she goes past the range of motion that I've set for her, she'll get bonus stars. Okay, that was a good example of one exercise.
In this exercise, standing tall with your arm alongside your body. Bend your elbow, taking your hand towards the shoulder.
So in this exercise, she's going to use a sort of feeding motion to do an elbow bend. And I'm going to ask her, for the purpose of the demonstration, to cheat a little bit, to bend over a little bit, to try and be out of posture and see what the system does.
Start. You've
Oh.
had an incorrect posture.
And in real time, it actually coaches her on how to be back into the right posture, which I think is fantastic. Yep, she got to her range of motion, which I think was about 120 degrees that I set for her. I just wanted to do 2 quick exercises. I'd obviously do more repetitions if this were an actual therapy session, but just show you what that looks like. Shelley, did you feel any pain during the session on a scale from 1 to 10?
About a 3
About a 3. And did you feel any fatigue?
and a 5.
A 5. So to the caller's question, that's how pain and fatigue are tracked by this particular system. Different systems have different way to track it. It now gives her a summary of the number of correct movements that she was asked to do, the total usage time, all those sorts of things. And it gives her some points, some gold stars for a job well done, so she can feel good that she got her session done the way her therapist had prescribed it. I'm going to finish this section and switch back to the therapy portal. So imagine myself in my office as a therapist again. I'm going to pull up Kelly Sullivan as a patient in the next screen. And this shows me all the workouts that she's done, or the latest workouts she's done. So we did 2 sessions yesterday and the one just now today. One of the sessions yesterday, she was unable to complete any of the tasks. I was able to communicate with her. I gave her a call, found out what was wrong. The system wasn't quite set up properly. So then we did another session lasting about 2 minutes, and she was able to complete those sessions. A nice little dashboard for me here as a remote therapist to understand what it is that the patient is able to do. And then if I click into one of those sessions, I get a little bit more detail. I'm able to actually look at the exercises that I prescribed to her and really understand in detail how she was able to accomplish those exercises, how long it took, did she have trouble, did she have pain, did she have fatigue. That's sort of the system in a nutshell. I hope that helps you imagine what these sorts of technologies that map patients in 3-dimensional space, paired with some really good exercise regimens, might be a future of where technology helps us in a path and a reimbursement model where minutes, face-to-face therapy minutes matter less, and you're looking for therapy efficiencies but still good outcomes. These sorts of technologies like Sword Phoenix can really help us accomplish both goals, getting better outcomes and getting them more efficiently. Thanks very much, everybody. I appreciate your time and attention.
Thank you so much, Peter and Shelley, for that great demonstration. If you have questions about the products that were discussed, please reach out to your Direct Supply account manager or to Shelley Wade, whose contact information is now on the screen. For more information about upcoming webinars or to view past webinar videos, please visit directsupply.com/webinars. Once again, thank you for attending today.